Thank you for the introduction. The endovascular therapy of thoracoabdominal aneurysm is a less invasive option and reduced the morbidity and mortality of the aortic repair in such patients, but it's not free from issues. And I would like to address 3 of those during the next 10 minutes. Starting with the access issues, which is a reason for unsuitability for endovascular therapy in patients with thoracic and thoracoabdominal pathology in about 20 to 30% of these patients. And such patients with tortuosity and calcification, they are not ideal candidates for such a repair. I don't know if you have paid attention to the live case. In this live case, a low-profile endograft was used, which is not made by stainless steel metal, but by nitinol, reducing the profile down to 18 or 20 French, which is extremely important so that we don't have to exclude so many patients of the. You have seen the case, and in case you have the desire to see it again, please go to Vascupedia and you can see a case done with a low-profile branched endograft. The second issue is the bridging stent, and Jim pointed out the new aspects of this, and we know that bridging depending complications are not very seldom, and they induce endoleaks and occlusion of the target vessels. In the past, we saw complications like this, fracture of the bear stent in this case due to the graft migration, or the complete fracture and separation of the fragments of this bridging stent used for branched endografting. Now we have many bridging stents on the market, but they are not dedicated for this indication. And no stent has real the quality for this indication. We have to cover the distance between the main body and the target vessel. We need a good visibility. We should respect the angulation of the target vessel, especially of the renal arteries, and the stent should be flexible but also durable after flaring during the cardiac cycles and also during the movements connected with the respiration and the remodeling of the aortic aneurysm. These stents should have also a high radial force and should be navigate good through the vessels and the stent graft, and should be very good trackable, and with a wide range of sizing and also oversizing. So you had access to this VBX some years ago, so you have more experience. And but based on the specific features of the VBX, the independent stainless steel rings, for example, this stent is flexible and was interesting from our point of view. But before we use this in the humans, we made some in vitro studies, and I would like to show what we have done with this stent. For example, in fenestrated situations. So Cook made this polyester stent for us. We had 10 fenestrations in it, and we put these different stents, I have to say, and we flared these stents. The first test we have done was a water permeability test, what was really good standardized, and we went with the pressure inside the stent up to the systemic pressure. And you see no water came after flaring of the stent out from the VBX. even if we went to 150 to 80 blood pressure, and I have to confess we went up to 300 without any leak. And you can see now the difference with the other stents, with another competitor, and you see the leakage of water coming from the stent. The second was to test also the fracture rate of these stents, and you see the digital radiography of the Advanta here on the left, and then of the B graft, and you see the changes of the metallic structure of the stent, of the B graft plus, and of the VBX, and you can have a personal idea of the changes of these metal structures. One failure mode in fenestrated graft is the dislocation of the bridging stent, and therefore was, in our eyes, important to know more about the pull-out forces which is required to pull out the bridging stent outside the graft. And you see we are pulling and pulling and pulling until the stent was completely removed from the aortic from the graft. And we measure the force, and you see we have two peaks because we have two rings inside the aortic portion, and you see here the forces were between 25 and 30, so more or less 27 Newton measured, and you see also the time. And we compared that with our standard of care, which is the Advanta, and you see that the VBX was not inferior to the Advanta in terms of maximal pull-out forces. This picture is, for me, is very impressive because it was done in a patient who had three different solutions. One with the stiff balloon expandable stent, one with a combination with the smart stent inside, and here the VBX, and you see how beautiful these graft combine well with the movement of the kidney. So we should go, yes. Well, the conclusion is that the BX provides precise delivery, a high radial strength, and post-market registry, which is starting during the next month in Europe, will show if it's all right. The third problem is the spinal cord ischemia, but I'm not sure that we can speak about this. During the live cases, we showed our strategy today, and our strategy is to use the SFS drainage only in high-risk patients and not in everybody. And we know the risk factors, and we stage our patients, and we do in one operation only for extent 4, but for the other thoracoabdominal aneurysm we use to stage always. And this is also another important point. We need early restoration of the pelvic and leg perfusion to reduce the risk. And if we have to repair the iliacs, well, we have to preserve the pelvic circulation. So going now to the, this is our current algorithm summarized. And in summary, the endovascular therapy is a less invasive option for patients with thoracoabdominal aneurysm. However, there are still unmet needs, and we have today access to lower profile endografts, have better bridging stents, in my opinion, and we have learned to deal also with this terrible complication, which is the paraplegia after the repair of a very huge aneurysm, especially of type 2. Thank you very much.